Can I just share my slides and see?
Yes, ma'am. Good evening.
Good evening. Yeah. Can be seen, no? It's okay.
Yes, we can see.
Okay. Actually, I'm at a wedding, which I left and came down.
Thanks so much. Today was, I think, being a holiday.
No,
But
I'm at a wedding here in Jaipur.
oh,
So I just went. Then I said, I'll just go up and come. I just told them. Very close friend's son's wedding.
and same thing, which currently is happening. It's getting live telecasted into two locations. One there's a CMA in Chennai, and one there's a CMA in Coimbatore.
Acha.
There are a few physical places also where people will be watching this.
Acha. So, Acha, you got that
Yeah,
physical.
so we have got doctors there, and they are going to be sitting there and watching it live on the big screen.
Okay, okay. Hi, Hema.
Hi, Madhuri.
Hi. I'm very overdressed, but it's okay.
Gorgeous. No, really nice. They have sent one backdrop, which I'm trying to just wait.
Hello, ma'am.
Who's
Sheetal,
that?
ma'am.
Repeat.
Sheetal, ma'am. Sheetal, ma'am.
Okay, okay.
I'm just trying to log through my laptop. Till then, through mobile, I've just joined, ma'am.
Okay, okay.
Good evening, Hemam, Nisha there.
Good evening. देखो
Thank
अभी करेक्शन का लग गया ना backdrop.
you.
ठीक
Hey,
है?
Your
मुझे भी भेजा है क्या? I can put it.
Yes, ma'am. Ma'am, I'll just forward you again once. Give me one.
Oh.
Madhuri, what I'm going to be doing is welcome and her introduction, your introduction, and I'm moving out. ठीक है? Then
So
after,
anyway, let her
after
start.
her,
Yeah, let her start then.
and then after her talk, na, you only thank her,
Yeah.
ठीक है?
And
And
then I'll
say
start
now we
again.
will move on to the conversation. I will not butt in again.
Yeah.
Okay. So you just keep looking at the chat box because when it's close, time for almost closing, I will tell you that now I'll take up audience questions करके.
Okay.
Then in the closure, obviously you'll thank her again and then leave it back to.
Okay.
Now we will move with Dr. Hema Devakar for the question answer session.
Yeah. Okay.
Okay. So we'll say we're ready to stump the experts and these are the questions and this, that, and the other, I hope. And Sheetal,
Yes, ma'am.
yeah, as usual from the chat now, if you can click
Yes,
and
ma'am. On WhatsApp, I'll be sending you, ma'am.
my personal WhatsApp, yeah?
Yes, ma'am.
So that
There's
I will.
no attachment, yeah?
Mhm.
No, there's no attachment to download. He sent me this thing.
Let me do one thing. I'll send you again this thing separately.
What weddings they have, Hima? My God, I always sad only after looking at them.
The big fat यार तेरा ड्रेस देख के ही मेरे को समझ रहा है कि कुछ तो है. Oh God. Because otherwise I've never seen you like this in a long
I
time.
know.
थोड़ा
I
तो
cannot change
मैच
to
होना है.
guys.
क्या करें?
I cannot change.
I've just sent
स्टार
you.
स्टडेड जो बोलते हैं डायमंड स्टडेड होएगा. Nisha, the first prayer and the walkathon, and then I'll come into the picture. ठीक है?
Yes, ma'am.
Sheetal? Nobody's speaking.
Yes, ma'am.
Ah,
Ma'am, 1 minute, I'm trying to join through laptop. It's
okay,
he had
okay.
sent the link on WhatsApp. So I'm
Hmm.
just trying to transfer that and try to join here.
Hi, Helena. The India team waiting eagerly.
Excellent. Right, you can hear me okay?
Yes, yes.
Yes.
Good. Hi,
Hi,
how are
Helena,
Helena.
you?
you may have to shift
Yeah.
your laptop a bit
Yes, I
back
will.
because
I'll do
you're
that.
cut here.
Yes, I'm going to fix that. I'm just also just fixing the background.
Sure, sure.
Uh, hmm. I might just have to blur it. I did send a message. I can't use the background slide that you've sent because it promotes one of the products I'm talking about in the talk. So I can use it if I
No,
can.
no, that's perfectly okay. Yeah.
I'm trying to use my usual background, but for some reason it's not coming up on the Zoom. So what I'll do, let's try. Huh, try to get a better background here. Bear with me.
Yeah.
Nishant, you send the background to me also? Through mail, is it there?
Sure, ma'am. I'll just put you on the WhatsApp. That's fine.
Yeah, yeah. I'll also just try to put that background.
Sorry, I'll just set up a new one. Won't be a minute.
Except during thank you time, na, keep your video off, Sheetal.
Yes, yes, ma'am.
I'll do the same when the dialogue starts. Yeah.
Yes, yes, ma'am.
Just give me a minute here. Sorry, I normally do have a background slide I just use, but this one.
I think we made you get up early, na, Helena?
Yes, very, and my husband as well. But that's all right. We're on holidays skiing in Canada, so. But that's all right. It's a very good audience you have.
So you can also recall what I said, a friend in need is a pest indeed. So we are true to
No, that's fine. I'm sorry about the mix up the other day.
Amanda was
Actually,
there on the call.
I won't do a background slide here, guys, because I'm going to end up covering up part of the slides, and I don't want to do that. So I'm just going to go back to our original slide. I'm just going to share these, if that's right, just to make sure that you can see the slides. And they only take the allocated time, the 20 minutes or so. And there we go. Hang on.
Yes.
Just making sure. There you go.
Yeah.
That's all right for you?
Yes. Perfect.
Yes, excellent. Now I'm going to lift this up higher. So better view. Is that all right?
Yeah, perfect.
All right, good.
Yeah.
What I'm going to do, let's just go back to.
Even this blurred background is looking really good. It's looking good.
Is it? I'm
And
good.
yeah, and then also your entire profile, the face is seen, so that's really good. Yeah. I think, Helena, actually we have 7 more minutes to go, but we may start in about 3 minutes or so because we have that short video which has to be played. So 8 sharp we will start this event, but ahead of that, that's why we're starting 2 or 3 minutes early. Yeah. Mhm. Mm. I think you're good with the slides as well.
Excellent. I was just going to see if I can just change that background and see if you can.
Actually, you go to that adjust background and effects.
Yes, I've gone there. It's just all my usual backgrounds for some reason are not there on this presentation. I've normally got about 10 of them,
No, but
including a PowerPoint.
you just press on add a image and then you'll get it.
Yes, so I've done that. I've looked for add image or add video. It's just not letting me necessarily do it. It will just give me one more, just another minute. Yeah, sorry.
Nisha, do you have some music for this holding slide?
On this, there's not. Shall I put something in the back?
Yeah,
Okay.
because in another 2 minutes you can.
Yeah, no, I won't be very long. Just
No problem. Because you still have 5-6 minutes, Helena, because we
okay.
have some background dance to do.
Oh, okay. It's very Indian. That's good. Hopefully, everybody is wearing their sari to do it.
Madhuri is wearing a very gorgeous sari. She is attending a
Good.
wedding.
Oh, really?
Ah, so
I'm
she says
No,
it's a
glad.
big fat Indian wedding, so she has to match the style.
excellent. No, you know what? I'm not going to do the background. I'll just use the one I've got. As long as that's not too disruptive, I'm
Mm,
going to move that over. And the lights are right at your end?
yes.
Okay.
No, I think we are good as you are. Yes. Yeah.
Madhuri, I've got my 22 minutes. Then it's just Q&A, and we go from there. Yeah?
Yeah. So what I will be doing is just making the introductions, and then I will say over to you, Helena, for your keynote, and I'll step away. After that, after you finish, Madhuri will get into the picture. You both will have the conversation, and when Madhuri says thank you to you and says now audience Q&A will take, then I will come back into the picture. Yeah.
Thank you. All right. All yours whenever you're ready.
Yes. Nishan, I would suggest that we are going to switch off our videos and the audio, and you can start the music for this holding slide and allow the participants inside, please. And then in 3 minutes' time, you start playing the mm, lighting of the lamp and the walkathon, and then we start sharp at 8, yeah?
Sure, ma'am. Yeah.
Yeah, Nishant, I'm making it live now.
Okay, sir.
You start, Nisha.
honored to be here today to inaugurate the Well Women Walkathon, a symbolic yet powerful initiative that underscores the importance of women's health and well-being.
Caring of women changes the life. Healthy women, stronger communities.
Namaskar and welcome to all our beloved delegates and our very distinguished faculty, Dr. Helena Teede, all the way from a holiday in Canada. And we offer a very special thanks to her for making this happen on the day that we wanted this conversation to happen. And our very own Dr. Madhuri Patil, both of whom will lead the Knowledge Cafe session. Ladies and gentlemen, what you just witnessed now was a walkathon, a wellness walkathon, which happened at the AICOG Mumbai just a few days ago. The Wellness Walkathon is not just a walk, it's a collective stride towards empowering women to lead healthier lives and fuller lives. It's a step towards ensuring that no woman is left behind in her pursuit of health, no matter where she lives and what obstacles she faces. We thank each and every of the Foxian and their leadership for their dedication and their presence not only at the walkathon, but their joining hands with every endeavor that we make striving towards women's wellness is a testament to the power of collective action and unwavering belief that together we can make a difference. This Knowledge Cafe is brought to you by Artist, which expands as Asian Research and Training Institute for Skill Transfer, and hosted by Farmit in their endeavor to do more and to do their best for making every woman an absolute woman in her journey through wellness for her body, mind, and soul. The topic being correct PCOS, we had envisaged 4 sections of this program. Once is not enough, says Dr. Madhuri, and I completely agree with her because it's time and again that the complexities of what the PCOS brings on the table, the debates, the discussions, and the decisions thereof led us to have a vision for a series of programs, the 4 C's, which is conversation, controversy, counseling, and case-based panel discussion. So the conversation was a podcast between Dr. Jaideep Malhotra and myself, which is already up in the air, and the controversies are on the guidelines, what it was then and what it is now. So today's very, very special session with very special guests that we have on board today. PCOS guidelines then and now. What's new? How we as clinicians need to change the direction of management that we offer to the girls and women across the entire life course on this issue of PCOS. For this, we have none other than the best in the globe, Professor Dr. Helena Teede, who is a FRCOG and a PhD, graduated from the Monash University way back in 1989. Her current roles are those of clinician, academic, and reproductive endocrinologist in Australia, the NHMRC Investigator Fellow in Women's Health, Director at the Monash Center for Health and Research Implementation, with a huge team of 120 of human resource that she leads, and she leads the Center for Research Excellence for Women's Health through the reproductive life. Needless to say, her global contributions have made a mark. World leader in PCOS, and we are so delighted, Helena, to have the brightest star in the galaxy to address us today. She spearheads the International PCOS Guideline Initiative, President of the International Society of Endocrinology, Chair of the WHO Task Force. A whopping 700 plus publications, 80 million US dollars grant funding as a lead investigator, and the awards include Order of Australia for Services to Women's Health, US Endocrine Society Laureate Award, international recognition for research excellence. What more could we have asked for, dear friends? We have the best being presented to you today. And I once again, on behalf of all of you, Formed artists and ourselves, thank Helena for being here with us to share her expertise and knowledge. To converse with her, to reflect on the then and now, we have our very own walking, talking encyclopedia, as she is fondly called in the country, Dr. Madhuri Patil, who holds the position of the Vice President of ISAR, Clinical Director of the Dr. Patil Fertility Endoscopy Clinic in Bengaluru, Associate Editor, Fertility Sterility, which is an official publication of ASRM, Chairperson of the Aspire Special Interest Group for Reproductive Endocrinology from 21 to 2025, President and Founder Member, Fertility Preservation Society of India, FPSI. I really am feeling like Shankar Mahadevan because it's a breathless list of things which I have to say about Madhuri. Vice President and Founder Member of the PCOS Society of India, Vice President of the Indian Society of Reproduction, which is ISAR, Board Member of AE-PCOS Society, Member Education and Accreditation Committee of Aspire, Associate Editor, Onco Fertility Journal, Past Editor-in-Chief, Governing Council Member of ICOG. Amidst the highlights of her award are the Durusha Lifetime Award from ISAR, Vidya Bhushan Award from ICOG. Is also, to add to this massive list, founder chairman of the Karnataka chapter of Society for Assisted Reproduction, which is called KISAR from our state of Karnataka, principal and course coordinator and examiner for fellowship certification courses, member of the International Reproductive Medicine Research Network. So it's time now to listen to the brilliant stars on the galaxy of the PCOS arena. To begin with, we will have a 20-minute presentation from our very distinguished faculty, whom we are very privileged and proud to present to you, ladies and gentlemen, Professor Helena Teede, who would give the keynote on the making of the PCOS guidelines, and then strike a conversation with Dr. Madhuri Patil for the discussions on what was then and what is the change brought about, and why is this change brought about, and how we as clinicians should translate it into our practice to reach every girl, every woman, everywhere, every time. So over to you, Helena, and heartfelt thanks once again on behalf of all of us listening.
Thank you so much. Yes, so I'm coming to you from Canada, but on behalf of the International Guideline Network, I will just share my slides now. And All right. I'm presuming everyone can see those. Okay, so I'm going to be talking about then versus now, what new 2023 PCOS guidelines say. And as noted, I do so on behalf of the International PCOS Network. I have no financial disclosures to declare, and the guideline work was funded in part by the Australian Government through the Centre of Research Excellence and also through the American Society of Reproductive Medicine and the European Society of Reproductive Medicine, as well as the European and American Societies of Endocrinology. So we're all very aware that PCOS is common, and as we all know, it's more common in India actually than it is in many other countries. The causes are both genetic, which is a polygenetic or mixed genetic cause, as well as lifestyle and metabolic factors, including our reducing physical activity and increasing BMI, which is occurring across the globe. That causes endocrine changes with insulin resistance and also high androgen levels and also neuroendocrine changes. That endocrinology underpins the clinical features, which include cardiometabolic features, reproductive features, dermatological and psychological features. As an entire condition, it is often underdiagnosed, misdiagnosed, or often as clinicians, we only treat the component of the illness that is actually related to our specialty rather than necessarily taking a holistic view. Therefore, the guidelines brought together groups from around the world, and you can see that included the PCOS Society of India, as well as the Asia Pacific Initiative on Reproduction, in which India has a key role, and the Asia Pacific Pediatric Endocrine Society. It included 40 societies from around the world, covering 71 countries, with input from all. It's very easy to find the guidelines. They are available freely just by searching Monash PCOS. There is not only the guidelines themselves, but a whole raft of resources for health professionals, a summary, and as I will talk about at the end, significant patient translation tools that are again free of charge. The important thing here is that the guidelines were a very rigorous process. They brought together experts from all different disciplines from all around the world, including India and Asia. They brought strong consumer perspective as well as evidence from research. And if anyone wishes to read the 6,000-page technical report, you're very welcome. And that summarises all of the evidence that underpins these recommendations. And cost and context and healthcare setting was also considered in the recommendations. So I'm going to talk first about what is new in diagnosis and screening. So traditionally, we used what was called the National Institute of Health, or the NIH criteria, which was consensus-based and quite narrow. Subsequently, we then used the Rotterdam criteria from 2003. The Rotterdam criteria have now evolved to evidence-based guideline criteria, and they are now the international guideline criteria for PCOS, which have surpassed the consensus criteria for Rotterdam. That we have separated out adult and adolescent criteria. We've enhanced accuracy of each one of the components in the criteria to improve accurate diagnosis. We've better defined each one of the diagnostic features and are re-evaluating cut points as evidence evolves. So importantly, the diagnostic criteria for adults now requires two of oligo and anovulation and clinical and biochemical hyperandrogenism and polycystic ovary syndrome. The new change in the new guidelines is anti-Müllerian hormone, or AMH levels, can be used to replace polycystic ovarian morphology on ultrasound. They cannot be used to diagnose the condition in its entirety, but they can replace PCOM. So two of those three criteria are adequate in adults for diagnosis. However, in adolescents, we require both oligoanovulation and clinical or biochemical hyperandrogenism, and we do not include polycystic ovarian morphology on ultrasound or AMH levels because these transition significantly with puberty and they're not specific for PCOS in adolescents. So in essence, the diagnostic algorithm now looks very much like this. And so what we're really doing is suggesting the first step here should be to assess menstrual cycles in every woman and adolescent who is presenting, who could have features of PCOS, And given that this now affects 1 in 8 women, it's a reasonable thing to suggest it should be considered in all women. And the other thing is that the menstrual cycle pattern is better defined. For those within the first year post-menarche, irregular cycles are quite normal. From 1 to 3 years, irregular cycles are less than 21 days and greater than 45. From then on until perimenopause, it is less than 21 days and greater than 35 days is defined as irregular cycles, or any period of amenorrhea not due to pregnancy or another cause for more than 90 days. So we've better defined those diagnostic criteria for menstrual irregularity. So the first thing is assess for menstrual irregularity. The second thing is then for clinical hyperandrogenism, and this should be done on the pheromone Galway or visual chart that's very easy to use and available readily online. It can include severe acne and scalp hair loss, and especially in India and Asia, also acanthosis. But in the context of PCOS, the most common tool that is used is the pheromone Galway for clinical hirsutism. If a woman has irregular cycles and has hirsutism based on the required score of 4 to 6 on the pheromone Galway, then she does not need additional blood tests. And this is important. They're only needed for exclusion of other causes, which we'll come to in a minute. But for 60% of women with this condition, all that is needed is a history and an examination. If it's not clear that they have clinical hirsutism or clinical hyperandrogenism, then the blood test, the free androgen index and total testosterone can be used. Additional blood tests, androstenedione and DHEAS, are not required and are not specific enough for the diagnosis of this condition. So if we just take a history and do an exam, we will capture most cases. For some women, they will need a blood test for total testosterone and free androgens. If they have both, as you can see on the orange box on the left there, they have diagnosis of PCOS unless another cause is found. If they're an adult and they have only one of those two, the cycles or the hyperandrogenism, then we can go on to do an ultrasound or an AMH. So you can see in adults, we only need to do that in about 30 or 40% of cases. For adolescents, if they don't have both hirsutism and irregular cycles, we do not do an ultrasound and we do not do an AMH. If they have one feature, we task them as being at risk and they're reassessed once they're around the age of 20. For those who are positive and look like they may have the diagnosis, other causes require a TSH, prolactin, 17-hydroxyprogesterone and FSH to be tested clinically, and then we also exclude rarer causes clinically and test further if necessary. And therefore, for the majority of women, the diagnosis is relatively simple. The important thing to note in terms of diagnosis and also screening is that one of the significant changes in the guideline is that women are now considered to be an increased cardiovascular disease risk. For those in the audience, you may recall, we know they have insulin resistance, hyperlipidemia, hypertension, increased BMI, increased rate of weight gain, increased diabetes at an early age, increased hypertension and gestational diabetes. But until this guideline, there wasn't adequate evidence to indicate they also have increased cardiovascular disease and cardiovascular mortality. And therefore, all cardiovascular risk factors are recommended for testing and screening at the time of diagnosis. So in terms of how we address the metabolic features, and this is more definitive in the guideline, we do seek permission to weigh women and explain why their weight is important in this condition. We focus on prevention of weight gain, of diabetes and of heart disease. And I know in India this is a particular problem. Unfortunately, our evidence review showed that no other tests are as good as the oral glucose tolerance test, and especially where the risk is high in India, it is recommended every 3 years. If it's not available or it's too high cost, fasting glucose is a reasonable alternative. HbA1c is not very good in women of reproductive age, especially looking for earlier stages of hypoglycemia. Blood pressure should be tested yearly, lipids at baseline, and then retesting if they have higher cardiovascular risk. I'll talk about this later, but lifestyle is primarily for prevention. Metformin can likewise be used in this case, and we will have some discussion about medical and surgical obesity. So just on the tests here, oral glucose tolerance test where you can, There is no point in measuring insulin resistance. It is too highly variable in clinical practice. A patient can vary multiple-fold in their levels by simply sitting for a brief period before a blood test versus walking the 200 metres into the clinic to have the level done, and it's not clinically useful at this stage. If they have PCOS, they are almost always insulin resistant. So in terms of testing, mostly clinical diagnosis. If you do need total testosterone and free androgen index, only in adults, either an ultrasound or an AMH, not both, but either could be the third test. We mentioned exclusion tests. All women should have cardiometabolic screening, and all women should have psychological screening. The prevalence of depression and anxiety in this condition are 80%. It has the highest prevalence of any feature of PCOS. And according to our patients, including those in India, it is the area that we forget the most. So what was new in psychological wellbeing and models of care? As I mentioned, very strong recommendations. The strongest evidence in the guideline were for screening of depression and anxiety. There are many very simple, very quick screening tools like the Hospital Anxiety and Depression score, which can be done whilst people are in your waiting room or even sent to them before the visit. It's important to note this condition has an 8-fold higher suicide rate in women, and it does have profound psychological effects. More eating disorders, body image, quality of life impacts are even more than diabetes. And one of the things that's proven to mitigate that is adequate evidence-based information, not Dr. Google, to ensure that the information needs and models of care of women are met. And this is a job for all of us. What is new in lifestyle? A couple of really key messages. It's important to make sure we consider weight stigma. People or women of this generation are not choosing to be overweight and obese. We are a product of our environment with less physical activity and with excess sweetened and processed foods and inadequate public health and preventative measures. In countries like India, where obesity is escalating, this is no different to our grandparents in many ways. We are not less disciplined. We simply have an environment that is obesogenic. In that context, judging the individual for their rising weight gain is unhelpful and just brings blame and shame. So it's important to make weight and to contextualise that as a clinical and health-related issue rather than a social and behavioural issue. In that context, the recent Lancet Commission on Obesity is a very useful document if you wish to read that, and it really defines clinical obesity as excess weight in the context of our environment with clinical features which include PCOS. The role of lifestyle here, importantly, is not for definitive treatment of obesity. The chance that your patients who have a BMI over 27 to 30 will correct that sustainably in the long term by lifestyle alone is negligible. And yet in the past we have advised our patients to eat less, move more, and that will fix their problem. The role of lifestyle is critically important, but it is not to fix obesity. It is to prevent weight gain no matter where their BMI is to start with, and to make them the healthiest they can be and to reduce complications. So lifestyle is important, but it's more about staying healthy than trying to treat something which is futile. Importantly, on the type of lifestyle intervention, there is no miracle cure. There is no PCOS diet. All of the healthy national dietary recommendations are relevant here. Less processed food, less fat, less sugar. Mediterranean diet is fine. There are modifications to the Indian diet which are possible to make sure that it's culturally appropriate. But the important message is there is no one diet, no matter what the social media influencers put out there, and restrictive diets are not helpful other than limiting processed foods. In terms of obesity, medical therapy, there is limited specific evidence in PCOS, although there is a recent published randomised controlled trial of GLP-1 agents and another one that's about to be published. These are quite supportive and show normalisation of many features of PCOS. So here we relied on the population level advice and the guidelines, being aware these agents should not be used in pregnancy and should be stopped prior to attempts to conceive. But one of the problems with the new anti-obesity agents is what we're seeing with women is if they lose weight preconception, they have a massive rebound of gestational weight gain when they come off the agents during pregnancy. And I would advise you all very strongly to be very cautious about this because it has significant pregnancy, mother and child complications. And in this case, you may consider using metformin and intensive lifestyle when they come off these agents. In terms of metabolic and bariatric surgery, this is probably an area we need far more availability. It has a long-term 20-plus year impact. It can normalise PCOS features. In this case, we do recommend in the guideline following population recommendations, but it does have quite significant metabolic, pregnancy and other benefits. It can also cause complications in pregnancy and needs to be monitored by a specialist team. What's new in non-fertility features? Just very quickly, as I mentioned, always consider PCOS in any woman overall, but especially with irregular cycles. We mentioned the new definitions of irregular cycles. Be aware that they have a much higher risk of endometrial cancer, in fact, tenfold for premenopausal women. We do not recommend routine screening by ultrasound because the absolute risk overall is lower, but we do recommend being vigilant about making sure women have either combined hormonal protection with the pill, an intrauterine device with hormonal protection, or at least 3 to 4 withdrawal menstrual bleeds per year, either natural bleeds that the woman may have or induced with progestin agents. Combined oral contraceptive pill is the first line for irregular cycles here, and we recommend low dose, not the higher 35 microgram ethinyl estradiol. The progestin in the pill is less relevant, in fact, probably irrelevant, compared to the first-pass hepatic effect and impact on sex hormone binding globulin and insulin resistance that we see with the low-dose estrogen-containing pills. Metformin and progestin can be second-line therapy, but be aware that metformin will improve fertility, which is good if they're seeking that, but not if they're seeking contraception. For hirsutism, the guideline highlighted the profound impact this can have on young women. We need to take it seriously, listen and empathise. Importantly, the guideline emphasised the significant new body of evidence around cosmetic or laser treatment, which can also be adapted for darker skin colours. It is very effective. It's more effective if you use it with a pill. It's been also shown to permanently reduce, not remove, but reduce body and facial hair and improve quality of life and mood. The other agents that can be used here are low-dose combined oral contraceptive pill. That needs to be used for at least 6 to 12 months before the optimum dose effect is achieved. Only after that time do we recommend adding anti-androgens, as there is no really long-term safety data with these agents, and we do not recommend using anti-androgens in isolation because they can affect the virilization of the fetus and they cause irregular cycles. So really, it's cosmetic therapy and the combined oral contraceptive pill that are first-line agents here. Just to give you a quick snapshot on the medications, metformin is indicated for all those who have a BMI of 23 to 25 in India, potentially for those with a BMI that's lower, for prevention of weight gain, metabolic benefits, ovulation, and it is a safe, low-cost, effective intervention for infertility, less effective than other agents, but very reasonable first line for a trial if you're not dealing with a woman who also has biological aging as a fertility issue. The pill is used for hirsutism, regular cycles, the SHBG hepatic effects. We prefer low dose 20 to 30 microgram natural estrogens, and we adhere to the standard contraindications. There is a limited role for anti-androgens only if needed and shouldn't be used in isolation and definitely needs contraception. In terms of inositol, there is a physiological reason why inositol may work in PCOS because it works on insulin-resistant pathways. However, the evidence quite clearly shows there are biochemical benefits, but the clinical benefits are not seen. We do not see clinical changes in cycle regulation. There is no improvement in pregnancy or fertility, and there is no improvement in hyperandrogenism. And in fact, in head-to-head trials, metformin is superior to inositol. If a woman does wish to take inositol because it's a natural substance, I would just remind people that metformin actually came originally from lavender and has been around for 100 years and is also a natural agent. Inositol does not cause harm and therefore is reasonable to use, but at the moment women should know there is not evidence for clinical benefit on high-quality randomised controlled trials, and that systematic review and meta-analysis has been published. Very quickly, the other key new recommendations were that all women with PCOS should have a reproductive life plan from diagnosis. They should be aware of the need for early family initiation. This is less of an issue in India, but in many Western countries where the average age of the first child is now above 32, this is a bigger issue to avoid biological aging in addition to PCOS. Also, earlier family initiation leads to usually a lower BMI at the time of conception. Emphasising healthy lifestyle and weight gain prevention throughout life from diagnosis for that prevention of weight gain and staying as healthy as they could be. Making sure they're getting their cardiometabolic screening done and managed pre-conception. We do not want these young women going into pregnancy with diabetes that's undiagnosed, with fetal abnormalities and complications. Making sure we always consider prognosis when we're talking about infertility treatment. A young woman who's relatively lean, who has PCOS and occasionally ovulates, may want to have a trial period of conception. They may wish to try metformin, low dose, low cost, less side effects. But if they're an older woman and they have a higher BMI and a poorer prognosis, actually going to other agents first or more effective agents is important. So it's important that they get accurate information in making this decision. There is a lot of misinformation available on this, and I'll talk briefly about where that can be sourced. So the management of infertility in PCOS has not changed greatly from the 2018 to the 2023 guideline. The blue pathway is the preferred pathway, and this now overlaps with the recommendations for the management of infertility in the WHO guidelines. So the diagnosis requires international guideline criteria. We need to optimise preconception health and lifestyle. Letrozole should be used first line with increasing doses as required, noting before there are options to use metformin or clomiphene citrate plus metformin as alternative agents. The other issue is if they're not responsive to letrozole, whether or not they're ovulating changes the recommendations, but if they're not ovulating, gonadotropins is the most appropriate second-line treatment, and only then IVF. Now, IVF is not needed for the vast majority of women with PCOS. However, it is quick and it is effective, but it is costly and it has significant side effects and a high risk of multiple pregnancy, especially depending on the technique. We do know currently that IVF is used more frequently in PCOS than it should be, and it's important to make sure women have the right decision aids and information to make that decision with their partner and their doctor in choosing the appropriate treatments. Importantly, the guideline also noted, which has not been highlighted before, that these women have much higher risk pregnancies, and yet often we don't even identify PCOS status in antenatal care. So for all your women with PCOS, when you're seeing them, you should advise them to let their obstetricians and midwifery and community team know that they have PCOS and that they are at increased risk. They have a much higher rate of weight gain, they have a high rate of miscarriage, gestational diabetes, hypertension, IUGR, and small for gestational age, not large for gestational age, which you usually see in high BMI and gestational diabetes. They have more preterm delivery and they have higher caesarean section. If there were any other condition that caused all of these, we would be jumping on it immediately in obstetrics, and yet it is not part of any midwifery teaching or textbooks and is not usually taught in the context of obstetrics and antenatal care. The other thing is metformin in pregnancy. We would love to say it makes a big difference, but in fact it does not. And indeed, the definitive paper from all of the previous metformin trials is about to come out, and it will show it does not prevent gestational diabetes. It doesn't prevent late miscarriage, hypertension, preeclampsia, or macrosomia. Probably it doesn't because of the mechanisms of insulin resistance in pregnancy. It can be considered in some circumstances because it does reduce preterm birth and reduce preterm delivery. It also does limit excess gestational weight gain in PCOS. So it's reasonable to consider it, but for the usual indications, it's ineffective. So very finally, there is a wealth of information and resources available to you and especially to your patients that are free of charge and are relevant to your health service context. And you can use the QR code there to access those, or just search Monash PCOS. That includes a wealth of consumer resources, which are in up to 15 languages and include top tips, little video clips, and written information, which is accurate. But the most important one is the consumer resource Ask PCOS. So this app is now used in 195 countries and is already used extensively in India. It has evidence-based information and also checklists to support interaction between the patient and their doctor when they're having a diagnosis and being tested. We also run a health professional course, which is accredited by Monash University, which is an international top 40 university, and those courses are readily available on the Monash website as well. So thank you very much. That's what's new in PCOS. That's a whirlwind tour. I'm going to stop sharing now and happy to do questions. Thank you.
Thank you, Helena, for setting the stage for the dialogue. And I think we'll first begin with the diagnostic part. So I would just like to ask you as to why were the criteria for ultrasound diagnosis being changed, and what are they now? And
yes, thank you.
we already know that we have to do an ultrasound only if the menstrual irregularity or hyperandrogenemia is not present, as you already said in your talk. So that would be the third criteria. It would be done only if either of them is not present. So why has the criteria changed for diagnosis, and what is it now?
Yeah, thank you. So good point. I should have put that in the slides, Madhuri. So it's greater than or equal to 20 follicles that are above the 2 to 9 millimeters. It used to be 12, but on current ultrasound equipment, they are now too sensitive, and we would be over-diagnosing the condition significantly. Really importantly, and I'm sure you all see this in India as well, in many countries, a young woman may have polycystic ovarian morphology, and that's all she has, but she's told she has polycystic ovarian syndrome and that she may have infertility. That is devastating and incorrect. So that's one of the reasons we also don't recommend doing ultrasounds in young women. Plus, often they're not sexually active, and rectal and abdominal ultrasound are inaccurate. So it's a vaginal ultrasound only over the age of 20 if needed for diagnosis. Different if you need to do it for clinical indications, but for diagnosis, greater than or equal to 20 follicles in that 2 to 9 millimeter range, or an ovarian volume greater than 10 millimeters.
We also, your guidelines also mentions about the number of follicles per section, also apart from the total number in the ovary. So what is that diagnostic?
I knew you were going to ask me that. I honestly can't remember off the top of my head. That must be the only thing I haven't committed to memory about the guideline. I'll look that up.
No, it's 10 per section, I think.
There you go. Thank you. You knew it and I didn't. I don't think I've ever had a question on the guideline before I haven't done, so well done.
Yeah, and also the volume, it should be
10, 10
yeah. And I think it also say, the guidelines also say that even presence in one ovary is enough for the diagnosis.
Yes, it does. One or both.
Yeah. Is the evidence now enough to use AMH alone for diagnosis of PCOS? Yeah. And we should also remember about the various assays and the different levels we get of the assays.
Yeah, it's a really good point. So I haven't given you a cutoff for AMH because exactly at that point, Madhuri, it depends on the assay. But it's likely by the next guideline update, which we may even do in the interim in those 5 years, we will be giving cutoff levels. It's just at the moment that different assays vary. So you should use your lab cutoff. In terms of the AMH, it is definitely not the only test for diagnosis. It is just used instead of ultrasound. So in other words, you can diagnose polycystic ovarian morphology on an ultrasound or on an AMH. Please don't use both because it is then overly sensitive and inaccurate. So one or the other. So
what would be your cutoff level be for diagnosing PCOS?
Usually it's about 4.5, but again, we don't give a cutoff level because it depends on the assay your lab uses. So what we do is recommend you to use your lab cutoff.
You've also mentioned about now the ethnic differences. So is it very important in the context of the Indian population?
Yeah, so interestingly, we've just published some of this work. So the Indian population in Southeast Asia has, and South Asia have a higher prevalence of PCOS. It's not that much higher as perhaps might have been expected when you go to a community population. So not looking at those women who turn up to a clinic with symptoms, but if you screen a population, and we've just designed a study called the PUT study, which is looking at prevalence of PCOS and features. And we've brought together community-based screened cohorts of high quality from across the world, including India. And that work is now just being published. And in essence, what we've been able to show is that there is between 10 to 13, 14% prevalence, with India being at the higher end. It's not 20 or 25%. And when we see that, we know it's being overdiagnosed. But it is higher in this population, so prevalence is higher. The metabolic features are the really big thing, Madhuri, and you know that. As with most metabolic conditions, diabetes occurs more aggressively, earlier, and more severe in the Indian population, exacerbated by the lifestyle, with less physical activity as a cultural background, and also higher weight gain. So what we're seeing here is really a very significant need to focus on the metabolic profile for Indian women. In terms of hirsutism cutoffs, India sits with most of the world in that 4 to 6 band. Again, the ethnic differences on that have just been definitively published, following on from the guideline, and India sits in that band. There are some Persian background, Middle Eastern background where the cutoff may be a little higher, but for India, the cutoff is the same. So it's predominantly metabolic. That is the biggest difference.
So even when we talk about the infertility management, though nothing much has changed, but it does mention that letrozole is a better drug for ovulation induction as compared to clomiphene citrate, though it is off-label. And these days, many companies are promoting extended treatment of either letrozole or clomiphene. So what's your view on the extended treatment? Because I mean, at least I don't use much, but there are many who are using letrozole for 10 days or clomiphene for 10 days, or they have the step up protocol where they stop for 5 days and again they start. So what's your opinion on that?
The evidence is not, so importantly, the great thing about the guideline is it's not about my opinion. And it's the best evidence we know. So there is not enough evidence at the moment for the extended protocols. And so people who are doing that are really trialing it. And if they're not doing it in the research context, that's not ideal. Letrozole is very effective in PCOS. And really, if we get through using letrozole in the first instance and it doesn't work, it's very reasonable to then go to gonadotropins. What we don't know at the moment is the efficacy of combined letrozole and metformin. It's really the only question of the infertility and perhaps the duration of the letrozole treatment that are still to be answered by evidence. But essentially, it usually works. And if it doesn't, then you could try adding metformin, but we don't know what that's going to do. Or you could move to gonadotropins.
Yeah. What about combination of letrozole and clomiphene?
Yeah, no, that's much more effective than letrozole. I beg your pardon. No, letrozole and clomiphene. No, you're right. Letrozole. Start again. Clomiphene and metformin combination is much more effective. Letrozole and clomiphene has not been used, and wouldn't well, it might have been used, but it hasn't been tested very much because it doesn't make physiological sense because they both work in a similar way, as well, in a similar action. So really, I wouldn't suggest people combine them. If it physiologically, it's letrozole. If you want to add anything, you would add metformin. But really, if letrozole is ineffective, you would go to gonadotropins.
Yeah, so I just like to mention, so through the International Research Network, we tried the study, I mean, where we gave a combination of letrozole plus clomiphene, then we had only letrozole and clomiphene, and what we found that the pregnancy rates were very low when we used a combination of letrozole and clomiphene, and therefore the study was basically abandoned because
Yes.
it wasn't right what we were doing.
So, yeah, we definitely, and that evidence would fit with the rest of the evidence, which doesn't support using them together.
Yes. What about IVM? in PCOS, but we know that the pregnancy rates are lower with the IVM, the clinical pregnancy rates as well as the live birth rates. And also the technique, what is required is totally different from the normal. And I don't think all the labs are geared up for it. So many a times, because it just mentioned, many people go on to do an IVM. So,
yeah. So with IVM, it is a really critical point you've made there. IVM should only be used in experienced hands and by laboratories that do it regularly. It is not something that we should be just offering if we don't have those services and that expertise in-house. Because the evidence that shows that the pregnancy and live birth rates are lower, they're in experienced hands. So that does not equate to what we see in inexperienced hands. So first of all, if you're going to use it, make sure you know what you're doing, or the person who's doing it does it regularly. Secondly, it's less invasive, it's lower cost, and therefore it's very reasonable to consider, as long as, for example, you're not dealing with prognosis factors. For example, if you've got a woman who's 30 who wants 3 children, you would not use IVM and necessarily, or 32 or higher BMI. But if you've got someone who's got time, who really only wants one pregnancy or one child, so it's about that nuanced individual perspective. It does work. It is less invasive. Some people prefer it, but only in experienced hands.
yeah. And the other thing is probably where you think the patient is going to go for ovarian hyperstimulation syndrome. That
Yes.
could be one of the indications for going about. What about continuing metformin? If the patient has been started metformin during the infertility treatment, what about continuing it once the patient conceives? Or do we stop it, or do we continue it?
So in the majority of cases, you would stop it. Now, it's almost counterintuitive. It lowers insulin resistance. It prevents excess gestational weight gain. There are lots of things it does do, and we don't really think it causes harm, although there's still some long-term effects to be sorted out. But the overwhelming thing is it doesn't really give many benefits either. And in the nausea, vomiting, hypergravidum, early stages of pregnancy, it does have, significant side effects. So the reason you would continue is if there's a risk of preterm birth or a history of preterm birth, or if you're really concerned about excess gestational weight gain. For example, someone coming off an anti-obesity agent and getting pregnant. Other than those 2 indications, for the majority of women, we recommend ceasing it.
Yeah. And many in India think that probably continuing metformin is good enough to prevent GDM, but you clearly said in your slides that it does not prevent preeclampsia or PIs. So I think this is a very good take-home message all our audience should have today, that it really does not prevent GDM or pregnancy-induced hypertension.
Madhuri, actually on that, you'll see the individual patient data meta-analysis is about to be published, and that is pretty much every large trial ever done with metformin in pregnancy. And it unequivocally shows no change in, I think there's a 0.01 change in fasting glucose and a negligible difference in GDM.
Yeah. And as you also said, that the lipid profile as well as the OGTT should be done in all patients who come to you yours at the first instance. And I would also want you to tell about the evaluating insulin, fasting insulin levels, postprandial insulin levels, or HOMA-IR, which I think many people still do.
Yeah. So insulin resistance is fundamental in PCOS. 95% of women who are above a healthy weight, which in India is a BMI of 23, will be insulin resistant on WHO criteria. 75% of those who are lean will be insulin resistant on those criteria. We know just by the fact that they have PCOS that they are insulin resistant, so 85% overall. But if we test it, so HOMA-IR is reasonable in an epidemiological study. It is no use on an individual level. And that's because the insulin levels themselves vary widely. So as I said, if you walk to a lab and go and have your blood test, or you've eaten or you haven't eaten, your insulin levels are dramatically different versus someone who sits and rests while they're waiting for their test. The other important thing is, whilst it widely varies and is not reproducible even in the one individual, it also doesn't predict response to treatment. So it's not like we can say if you've got this, you're going to respond better to metformin, or if you've got a high level, you'll respond. The bottom line is if you have PCOS, you are insulin resistant, full stop. And in fact, probably a better test material is their SHBG. Their SHBG is usually low, as we know, is a pretty good marker of insulin resistance. And in fact, it's one of the ways of differentiating hypogonadotrophic hypogonadism in our exercising lean young women, because their SHBG is usually high. So you'll see a higher SHBG in there, whereas you'll see a lower SHBG in PCOS. So if you have to measure anything for insulin resistance, SHBG is the one to measure, and really important to know that.
Yeah, and when you measure your SHBG and your total testosterone, you also get your free androgen index, which is most important. And that's the only test today what we really do in all our patients to diagnose biochemical hypoandrogenemia. And I think even hemoglobin A1C should not be used as a diagnostic modality for diagnosing insulin resistance. You also mentioned
Actually,
about
really important, just really important on that, Madhuri, the HbA1c is not accurate, neither is fasting glucose, especially in reproductive age women. So premenopausal women and PCOS, and it's in part related to hepatic glucose metabolism. But we know it's the postprandial hikes that are really the cause of the problem, and that's why we need the OGTT.
Yeah. You also spoke about increased incidence of sleep apnea. So do we test for it? Do you do a specific test for it, or do you do it only in obese, or do we do it in all PCOS women?
Yeah, so obstructive sleep apnea is 10 times higher, as is endometrial cancer. And with sleep apnea, though, for a long time, because it's associated with insulin resistance and metabolic features, it was felt that we should be screening for obstructive sleep apnea in this condition. However, the evidence now from the sleep literature is unequivocally that just treating sleep apnea doesn't make the metabolic rates better, doesn't affect the insulin resistance, doesn't affect the cardiovascular risk or diabetes. So the only reason to screen for obstructive sleep apnea and PCOS is if women have symptoms. If they are tired, fatigued, snore, sleep poorly, have a collateral history from a partner that they have those features, then they should be screened. And the way to do that, and we recommend screening with this, is to use the simple Berlin tool. Don't use a lot of the other tools because they require gender. So as soon as you say female, they will exclude you. But the Berlin test is quite a good one, and really just ask them, are they sleepy, tired and snory? And if they are, then they need further investigation and follow-up.
Again, you also said about the anxiety and depression being higher. And usually, as clinicians, many a times we ignore that symptom of the patients. So when the patient comes to you for the first time and you diagnose PCOS, do you think we need to give them forms wherein, where they can fill, and then we can probably
Definitely.
that whether they have some amount of anxiety, depression, or other mental disorders, so that then we can direct a treatment towards that?
Yes. So really important point. If you go away from today's discussion with two key points, one is make sure that the diagnosis follows the criteria. The second is please screen for depression and anxiety. The prevalence rates are so high and we dismiss it. And as I said, the suicide rates are 8 times. It impacts quality of life more than diabetes. Those very quick tests, the hospital anxiety depression tests, are freely available online. They're a tick box and a score. When my secretary sends it to my patients before they see me and they bring it with them, it takes me 30 seconds to calculate the score, and then I need to go and address it. Importantly, what we don't want is for all these girls to be put on anxiolytics and antidepressants. What we need is to look at that and go, okay, this is causing them some distress. Is it primarily their PCOS, and what is their biggest concern? Often it's that they may not have children. And on that, and I should have said that in the talk, and I apologise I didn't, the critical message we must deliver is that for the vast majority of women with PCOS, they will reach their aspirational family size if they have access to medical therapy to support them. So what we do know is if we miss the diagnosis in adolescence, if we just treat the symptoms with irregular cycles and OCTs and we don't make a diagnosis, they are more likely to be nulliparous, and less likely to reach their aspirational family size. And we really don't have a right to ignore a serious condition and not tell women they've got it. So early diagnosis is really important, very, very critically important. But often just knowing that it's causing distress, anxiety, and depression, understanding what it is about the condition that's causing that, and then making sure, usually it's just giving them the app, which will explain about their family size, explain that they can prevent the complications, make sure they understand the condition. We know information ameliorates that anxiety and depression. And treatment, for example, treating the hirsutism makes their mood better. So before rushing into anxiety and depression treatments, find out if it's there, find out why it's there, and help them with information such as the app, because we can't do everything in one consult. You and I know it takes such a long time, but if we give the women the app, as I said, it's free of charge. There's no, it's a guideline associated, but it allows them to put their main concerns in and then gives them the information to assist them.
Yeah, and probably, especially in adolescent, counseling of the family also is very, very
Yes.
important along with the patient. I mean, that would really make a great difference.
Yes.
You also spoke a lot on the lifestyle modification, where you spoke on various diets, and there's no specific diet or exercise which you recommend. You also spoke on metformin, probably, which helps in reducing the weight. So, what is it about the GLP-1 agonist? I mean, do they really help much more? They're much better than metformin, or you think metformin is better?
Yeah, so there's not a head-to-head trial. There's hardly any head-to-head trials in question, but also there's very few trials of GLP-1 in PCOS, and many of them are not high quality, or they report overlapping studies, which is actually highlighted in the guideline. There is an excellent randomized control trial that was recently published in New England Journal of Medicine, and there's also, or maybe in the Lancet, and there's also one that's about to come out in adolescents. What it shows is they do exactly what you would expect. They have significant nausea, vomiting, bloating, side effects, and cost, and they have significant weight loss of around 20%. And that weight loss, and with the newer agents, with multiple agonists, they have around 25% weight loss for quite a substantial proportion of patients. Many of those will dramatically improve their PCOS features, but the moment they come off the agent, they will regain the weight. And we know that weight regain happens. So if we're going to use this treatment, it is long-term, which is why we need to think about, if you've got a young woman and you're looking at a GLP agent, which is costly with side effects and, it bounces back immediately, there's a very good reason for considering metabolic surgery, because it's sustainable, effective, and in the end, lower cost, lasts at least 20 years, but we just need to be careful around the pregnancy complications.
Yeah, and moreover, they cannot be used. I mean, the patient should not conceive when they're on GLP-1 agonists, because it's still, it's not still considered to be safe when it's used. Even the incidence of bariatric surgery is increasing today, especially if the BMI is more than 35. And but it's also been seen that they lose weight for some time, and again they start gaining weight. So
it depends which one they have, though, Madhuri. So the band was seen to be the simpler one because it was reversible. We could expand it, take the fluid out in pregnancy, etc. That's the one where weight regain is most troublesome. The other ones, the Roux-en-Y and the gastric sleeve, the data long term is much more sustainable. And whilst they may regain some weight over time, it's pretty limited, and the impacts over 20 years are still quite profound, as well as very substantial health benefits.
Yeah. The other thing is though we know that the cardiometabolic risk is very high in the woman with PCOS, but in the guidelines, there's nothing been mentioned about the NASH and NAFL, as well as increased inflammation, which are usually associated with insulin resistance. So was it because the evidence is less, or what was the reason that it's not been mentioned in the guidelines?
Yeah, good point. Well, there were two reasons. One was it wasn't prioritised by the 7,000 world experts and women with PCOS around the world enough that it would be included. So next time, unequivocally in the next round, it will be, but this time it was not prioritised for inclusion. The other reason is the treatment is non-specific. All we would do is say to a young woman or a woman with high BMI and PCOS, you also have this, which is just another clinical feature of their PCOS, insulin resistance and obesity. There's no specific treatment. The treatment is exactly the same. And the overwhelming majority of women with obesity will have metabolic alcohol, non-alcoholic steatohepatitis. I always forget the new name for that condition now, Harry. So they will have hepatic infiltration. And the point is that we don't do anything different about it. It's just another one of the features of the condition. But in the next round of the guidelines, we will definitely address it because it's increasingly now causing hepatic cirrhosis.
Yeah, because nowadays in India, at least we see that there is a little bit higher incidence of liver
Yes.
disorder in these women. So that's what I thought. And what would you talk about male PCOS? Because even in the guidelines, it's been mentioned that the male relatives of
Yes.
PCOS women have a higher incidence of metabolic disorders, but not the female.
Yes, interestingly, we can't necessarily say not the female. There's not enough evidence, surprisingly, for female relatives, but there is for male relatives. In fact, there's even some suggestion that much of the genetic code might actually come from fathers, the metabolic genetic code. So what we know is that male pattern baldness, male central obesity, and metabolic features actually cluster with the polygenetic description for PCOS. So there's a genetic type of PCOS in men. It just doesn't involve the ovaries, clearly. And that seems to be linked to male relatives and female relatives with PCOS. So it's not, I think it's really important because it highlights that this is not all about the ovary. And that comes to the next really important thing, which is we need to change the name of the condition. And that's now underway with the Centre for Research Excellence in Reproductive Life and the Androgen Excess and PCOS Society to go through a process to change the name of the condition that will reflect the fact that it is a broad cardiometabolic, reproductive, psychological, and dermatological condition.
Yeah. Do you think there's a link between the brain and the gut in women with PCOS? This is apart from the guidelines. I'm just
Yeah, definitely. So the mechanisms, we don't know enough about the cause of this condition. You mentioned inflammation before. We know that it's insulin resistance, it's inflammation, it's adrenergic stimuli that all come together. It's partly genetic and partly environmental. It's partly epigenetic. It's a bit like diabetes and obesity. They're just a complex array of factors. So we end up dealing with what we see at the tip of the iceberg. But definitely there are multiple factors, and we do know that neuroendocrine changes are important. And so, yes, that unequivocally, and in fact, some of the new treatment options that are being looked at will actually be brain targeting.
Yeah. So we in the guidelines also we know that there's nothing changed from the previous and this time about the incidence of endometrial cancer, which we know that it's almost 3 to 4-fold increase. So do you recommend testing for atypical endometrial hyperplasia or endometrial carcinoma in these women at a younger age, depending on certain factors, or?
No, really important. Oh, so on certain factors, yes, but not routinely. So the reason for that is even though it's a 10-fold prevalence, what we do know is that the absolute risk is very low. So we would be grossly over-screening and over-investigating if we ultrasounded everybody. So the recommendation is if there's been prolonged periods of amenorrhea, if there's abnormal bleeding, heavy bleeding, etc., then further investigation should occur. But the primary message about endometrial hyperplasia and cancer is don't let them get there. Is make sure they've got prevention, make sure, which is very simple, make sure they're getting adequate progestin either through ovulation or through contraceptive pill or an IUD or through intermittent progestin.
Yeah, because many a times we can see that if there is atypical endometrial hyperplasia or in patients where we've diagnosed endometrial cancer, on day 2 of their cycle, usually the endometrium does not get thinner than 8 millimeters. So I think that could be one of the indications where probably we could, screen them for having endometrial cancer,
Yeah, there is.
endometrial biopsy.
Sorry. Yeah, sorry, I didn't mean to speak over you, Madhuri. If you look at the guidelines, we do make some clinical practice statements around where it may be indicated, but the most important message is it's not routinely indicated.
Yes. Uh, and when we talk, you spoke about the combined oral contraceptive pills. You also spoke about we should use a lower dose of estrogen that's less than 30 micrograms. What's the best progesterone you think should be used along with?
Yeah, so the message here is there isn't a best progesterone. And yet, if you listen to pharma and some of the drug promotion information, they will convince you one progestin is more hyperandrogenic or less hyperandrogenic than others. Doesn't really matter. The evidence shows that it is the liver effect, so taking oral estrogen, processing it through the liver, dramatically increasing your SHBG and soaking up all the excess androgens are far more important than any minuscule difference in the androgens. In the progestins. And even to the point that sapronolactone acetate is not recommended long term. It has other side effects. It also can exacerbate mood and weight issues, and so therefore we don't recommend a high dose sapronolactone acetate in that context. There may be some marginal benefits of one over another, but then there's also the venous thromboembolism and other risks to consider. So overall, our message is the estrogen is much more important than the progesterone, and make sure that you use a lower dose of natural estrogen if you can.
What about the anti-androgens? Would you use them in patients who have severe acne and hirsutism, or would you use them only if the COCPs fail to reduce the hirsutism and acne, or how would you go about?
So for acne, I would use other agents as well. If it's severe, for example, Roaccutane and other agents if needed, because there's better evidence for those. For hyperandrogenism with hirsutism, I would use laser because, again, that's got good evidence of permanent hair reduction. Anti-androgens have a limited role, and the limited role would usually be on failure of other treatments. The exception would be where they've got significant scalp hair loss, and that's because once it's occurred, it's hard to correct, and it's quite debilitating and distressing. So if you've got a young woman who's getting rapid progressive hair loss, keep in mind weight loss, diet, exercise will make a difference almost certainly. But if they've got rapid excessive hair loss, then it's reasonable to add an anti-androgen fairly early, because once that's occurred, it's very hard to correct.
Do they have any effect on the sexual function as well as on the fertility part of it by the anti-androgen?
Really good questions. There's not enough evidence, Madhuri. You would expect they would. In fact, the evidence around libido and the use of the pill in and sexual function in PCOS is limited, actually, and is an important area. But in terms of anti-androgens, very limited evidence.
So the last question of mine would be what steps would you take once you diagnose PCOS to prevent long-term complications?
Education. And that's education of health professionals, but also education of women and all the parents of young women, partners. The healthiest they can be is critically important. And if we set women up to fail by saying lifestyle is what you should be doing for weight loss, they'll stop doing it, rather than lifestyle is something you do permanently, just like diabetes. You don't eat sugar, you look after your health. PCOS should be the same. We be as healthy as we could be is critically important. And the other thing is setting up a metabolic and a reproductive life plan.
And would you advise regular testing for their blood sugars, the BP, lipid profile?
So blood pressure is every year. Weight is every 6 months to a year. Glucose is a minimum every 3 years with an oral glucose tolerance test, or preconception and in pregnancy. And lipids is only initially, or if they've got multiple other cardiovascular risk factors.
So I really thank you, and I think we've covered most of the things what have changed in the guidelines. And I think our delegates would have definitely benefited, and probably they would, I think they would change something in their practice. So I think we'll go with the question answers, Emma, or?
Yeah, thank you so much, Helena and Madhuri. This was such an engaging and an insightful discussion. And it's been a wake-up call, I think, for all the delegates here who have now recognized why the guidelines were changed, what was it then and what is it now. And when I mentioned wake-up call, I must confess that I'm really, really guilty today for having woken up our distinguished faculty, Helena Teede. I know she lives in Australia, and that's how, some timing was planned, but she's on a holiday in Canada. Midnight masala, we call it in India. So, we woken you up, and we are really sorry for that. But, it was such a worthwhile, such a meaningful conversation. And generally, when two experts speak, the title is Fireside Chat. And I must say that both of you have really put the stage on fire because it's really been such a learning for all of us. Talking about fire, there'll be a rapid fire round of questions. Soon after, I would request Madhuri to share 4 or 5 slides of a rapid recap of what the conversation has been about. The initial idea was that you take up one segment and the slide, take up another segment and one slide. But last minute, Madhuri and myself decided that we don't want the interruptions. It was such a delightful, seamless conversation between the two of you. Now I would just request Madhuri to quickly share the slides, and I will shoot the questions soon after.
Yeah, so basically we discussed about the ultrasound, and what I just want to say that it's not necessary if you have irregular menstrual cycle and hyperandrogenism. The follicular number per ovary should be more than 20, and per cross section it has to be more than 10 for diagnosis. Also, we know that today AMH can be avoided, and as we already spoke, we should do only one of them, and both should not be done to avoid any overdiagnosis. We have to take into consideration the age of the patient, because we need to know that AMH peaks between 20 and 25 years. It is lower in those who have a higher BMI, and also is lower in those women who are on oral contraceptives. And therefore, we need to wait for at least 3 months before we assess AMH when the patient is on the oral contraceptives. And initially, it was thought that we could do AMH at any time of the menstrual cycle, but now we know that it varies across the menstrual cycle, and therefore it's best to do it on day 2 or 3 of the menstrual cycle. We've already discussed that there's an increased prevalence in South Asian groups. Periconceptual risk factor screening is very, very important, which was another new points which were added in the recommendations, and especially in those women who are planning for pregnancy, where we need to check their weight, their blood pressure, and also look at their lifestyle modification, which is again very important. As we said in ovulation induction, nothing much has changed. Letrozole is a better drug than clomiphene, and anisetols in any form basically are considered as experimental therapy, but they could be used because they do not have much side effects. When gonadotrophins are used, it's important that they have to be used on daily basis. You can combine gonadotrophins with oral agents, but the guidelines say that gonadotrophins alone are much better. Again, when we compare gonadotrophins and laparoscopic ovarian drilling, gonadotrophins would be a better option. We have spoken about in vitro, which should be done only if expertise is available and not otherwise. And cardiovascular risk, again, we need to screen for lipids in all the patients and not only in those who were obese, as the previous one said, the previous guidelines said. And the blood pressure also should be measured annually, especially when you're planning for pregnancy or for fertility treatment. Coming to type 2 diabetes, we've already discussed that basically we have to do a OGTT. Fasting glucose and hemoglobin A1C are second line tests and should not be done as first-line test. And as we already said, fasting fasting insulin levels and HOMA-IR really do not have any value. And all these recommendations have become evidence-based from clinical recommendations. Obstructive sleep apnea, only in those who are symptomatic. We need to test for sleep apnea. Depression and anxiety is very important, and basically we have to use a validated screening tool for all the patients who come to us. Lifestyle is very important because weight gain has a stigma, and we need to look at what are the factors which affect the weight gain, and therefore we need to first treat the underlying mechanism, and also emphasize on diet as well as exercise. As we said, GLP-1 could be used, but it's better to avoid them because they do cause weight loss. But once you stop them, again, weight gain is seen with these drugs. Bariatric surgery only if the BMI is high, but again, we need to keep in mind that after bariatric surgery during pregnancy, it may affect the growth of the child, and we have to monitor for IUGR. We've already just discussed about the combined oral contraceptives. Any progesterone can be used, and the guidelines do not recommend one over the other. But what they recommend is a lower dose of less than 30 micrograms of estrogen that needs to be used. Coming to anti-androgens, basically spironolactone is the most used one. That also, if the oral contraceptive pills are not effective in reducing hirsutism as well as acne. We have already looked at the prevention of the late sequelae, wherein regular weight and BMI assessment is important. Glucose screening, again, is important. Blood pressure should be checked annually. Lipid screening should also be done annually if they are on the higher side, and also depending upon the risk. And one must screen for obstructive sleep apnea and endometrial cancer if required, and it should not be a routine screening. So one needs to balance the benefit with evidence when treating women with PCOS. And I think eat less, eat on time, eat right, walk more, sleep well, and smile is the mantra of having PCOS women without any symptoms and signs, and also improving their well-being. Thank you.
Thanks yet again, Madhuri. And we will now take the audience Q&A, this section. Even I will move out of the slide in a minute, but just want to place on record that as a division director of the FIGO Well Women Healthcare, we have often discussed the life course approach. At every point in her life, there are issues where preventive care and the journey of wellness should begin, and PCOS undoubtedly is one such issue which cuts right across all age group in the life course. Gulshanara from our team in FIGO has placed a question about nutritional intervention, and she very well knows that mental well-being and nutritional intervention, these are the two things that, because lifestyle is now the center stage of so many issues that are, causing a havoc in the well-being of girls and women. So these are being paid a lot of attention to right across the lifespan. And the point about the checklist and the use of technology, that is, give the checklist by a Google form or whichever simple way you can to the patients, even ahead of their dropping by at your consulting, and it'll save time and quickly let you judge and gauge what the level of anxieties, depression could be. And I think this additional piece is already being done in perinatal mental health issues, where antenatal and immediate postpartum, we are doing it in several of the capacity building courses in India, but we need to extend it again right across the lifespan. So now to the questions. There are a whole bunch of questions on metformin. So let me just finish that first. There is Bharti Mishra, there is Lata Gupta, there is Vidyashri, and many more who have asked questions about metformin. By the way, the webinar views, as well as the YouTube views, as well as live audience in Chennai and Coimbatore, all have given some very rave feedbacks about the discussions which are already on. So thanks again. Now, the question on metformin is metformin advisable in adolescent PCOS with irregular cycles? Do you give it alone or with OC pill? And how long it can be used in the PCOS patient? Helena?
Yes, sorry, I can jump in here, and Madhuri obviously can also jump in. You may be looking at a different order of questions to the ones I am, but metformin can definitely be used in adolescents. The evidence for it is less convincing than it is in adults, meaning there's less studies, but the evidence still suggests that it can be used. And usually we would do the starting at the 500 milligrams per day, and keep that for 2 weeks, and then increasing up to a maximum of 2,000 milligrams per day if tolerated. In terms of how long someone takes metformin, it really, however long they need the benefit, the therapeutic benefit is really the answer we give. There's no concern about long-term use of metformin in these women. There is a question about B12 levels, and there is increasing evidence that there may be B12 deficiency with long-term metformin use. So one of the things that we are looking at, which was not enough evidence for this guideline, but maybe for the next one, is just considering B12 levels. And given that in India you've got a high rate of vegetarian populations anyway, and anemia and other concerns may be more relevant, that may be something else to consider.
Right. Thank you, Helena. The next two questions are somewhat related to metformin, obesity, GDM, and pregnancy. This is the mix where, again, the issues around metformin is being questioned. If we continue metformin in pregnancy in obese PCO patient, till what gestational age we should give? Should we stop as soon as she conceives or at first trimester? Because you categorically said that if your thought process is, oh, she may develop GDM, let me just continue, that's a no-no. That's quite clear from the so, but when she's already on metformin and she conceives, till when should you continue?
So look, there isn't an urgency in that the concern about side effects or adverse effects are largely the ones we're very familiar with: nausea, vomiting, diarrhea. If they have minor or no side effects, and it's not urgent, and the evidence about long-term harm is very limited. In other words, there's very limited evidence it does cause any long-term harm. So it's not an issue of urgently having to stop the metformin, which is what we see with many drugs in pregnancy. We want to stop fetal exposure. It's more the context that it doesn't offer benefits for the vast majority of women with pregnancy, and therefore it's more about saying, now that you're pregnant or when you get pregnant, just stop your metformin. So it's not so much a specific gestation, it's as early as you happen to have that discussion, and definitely if there are side effects that they're having.
And in continuation, Helena, if the PCOS patient is already on metformin and she indeed develops GDM, how do you then manage it?
Yeah, really interesting. And this evidence will also come out fairly soon. Metformin is not very effective at managing gestational diabetes, probably for the same reason it's not very effective at preventing it. So it's quite useful for insulin resistance outside pregnancy. It's useful for the prevention of diabetes. It's useful for the treatment of diabetes, but the nature of the condition in GDM is different, and therefore it's not very effective in treatment. In fact, in PCOS and non-PCOS, and this data again will be published shortly from the individual patient data meta-analyses from multiple trials in multiple countries, if you use metformin to treat GDM, it makes no difference on the to the usage or requirement for insulin, or indeed to the dosage requirements. So really, I wouldn't use it for prevention, and most countries don't recommend it for use for treatment either, because it just doesn't have the efficacy.
Right. And, more and more the clinicians are now being sensitized to the fact that pre-pregnancy, that is preconceptional and interconceptional care, you need to focus on the preventive care, the lifestyle and the glycemic status, and all of those should be really, really paid attention to. And you continue what we call the medical nutrition therapy across. And hope that you may not need any addition, either of metformin or insulin. So as long as you can carry her forward with the euglycemic status for a number of weeks, and that'll be a good thing to do. Now, Madhuri, some infertility related questions again with the metformin. Do you recommend using metformin with letrozole also for induction? When you're giving letrozole, do you have to just
Yeah.
co-prescribe
I
metformin?
think
That's one question. And then there is an interesting question on when do you do ovarian drilling in the middle of all this, Madhuri?
so basically, Helena very clearly said that there's no advantage of combining letrozole with metformin, though there is advantage of combining clomiphene citrate with metformin for ovulation induction. Laparoscopic ovarian drilling in the Indian context should be done only if the patient cannot come really to take, cannot afford gonadotropin. Second, she cannot come for monitoring. In these cases, especially if it's a lean PCOS, having high LH levels and high androstenedione levels, if at all they are measured, these are the indications for laparoscopic ovarian drilling. That also should be done in such a way that you don't you don't overdo it. You have only 3 to 4 punctures. Just keep the current for 4 seconds and not more than 40 watts.
Right. Again, see, there are so many, nuances in using the metformin at various phases. So there are still questions pouring in on the same issue. Metformin in lean PCOS. Repeatedly, the delegates are asking that question. And also the issue about using oral contraceptive pills to regularize the cycles. You use it for 6 by 12, 6 months, 12 months. The moment you stop it, like dog's tail, it comes back again to irregularity. What do you do then?
Yeah, so I'll jump in, and then if Madhuri wants to add anything. So in terms of the oral contraceptive pill, you're treating a long-term chronic problem. It's the same as if you have hypertension, you don't give someone an antihypertensive and then expect to stop it unless they lose weight or change something that would reduce their risk. Same with hyperlipidemia, same with obesity. The obesity medications, if you use them, they are long-term therapy. Same with metformin and the pill in PCOS. There may be times where the indications may change. For example, they may want to go into infertility treatment. They may want to swap between the pill and metformin. They may get pregnant. So there are reasons why you might stop it for different life stages. But this is a chronic condition. So the treatment is going to be long-term. And then it just becomes a question, if you're using the pill, are they getting higher metabolic risks as they get older? Is there side effect profiles we need to consider to balance out here? So it's a matter of re-evaluating the treatment risks and benefits in each individual woman on a regular basis. But what we're talking about is usually chronic therapy for a chronic condition.
Yeah. Thanks, Helena.
Yeah, so here again, I would like to say that it's important, as she said, to evaluate also whether the patient is at a risk of thromboembolic events. And therefore, if you have certain patients who have a higher risk of having that, then it's better to give progesterone in the second half of the cycle to regularize rather than giving combined oral contraceptives, especially if she doesn't have much of hirsutism or she doesn't have much of the acne. And also the metformin in lean patients, it's important. Why? Because it's not only obese that are insulin resistant, but it is also the lean PCOS that are insulin resistant. And therefore, metformin is useful not only in the obese, but also in the lean.
Right. And Vidyashri Kamath asked Madhuri that
I think
OCP
Helena
containing...
also say
Yeah,
something.
Helena? Sorry, I didn't know.
No, I just agreed with you. Metformin is definitely also useful in lean PCOS, sorry.
Yeah, thanks. Vidyashri Kamath. She said OCP containing drospirenone. Is it superior to other OCPs in PCOS with acne?
No.
No, the evidence is not strong enough that any one anti-androgen should be used. If anything, sapropterin acetate, the benefits may be slightly more, but there are more side effects with this agent. So on balance, we emphasise that we would not choose a combined oral contraceptive pill based on the progestin, even if it was drospirenone, and rather would focus on the natural low-dose estrogen component as being the most important.
Right. There is Sneha Naveen and Brinda Chinnappa. Both have questions on which anti-androgen is good to prescribe for hirsutism and for how long.
So the anti-androgen we would recommend is spironolactone. We don't recommend sapropterin acetate or finasteride. They have significant additional side effects. But again, we would only use that initially if it was for severe hair loss, or if failure of other therapies, for example, cosmetic therapy and the pill, then mandated the addition of anti-androgens. But we really do not use them very often. There is pretty much no long-term data on the safety of anti-androgens in women.
Interestingly, there's one question on melatonin, the role of melatonin in PCOS.
So we have limited evidence about the role of melatonin, and also just about nutritional supplements. I want to make a comment on that as well. We've just published a systematic review and meta-analysis on this. At the moment, there may be agents or nutritional supplements that might be useful in PCOS, but the studies are very poor quality, and there are currently no recommended supplements that actually are proven to make a clinical benefit. We talked a little bit about inositol before, and there's more evidence for inositol than others, in that it doesn't cause harm, but it also causes no tangible clinical benefit, only biochemical benefit. But for other supplements, there is even less data. So the nutritional side of focus in PCOS is very much about healthy lifestyle, moving, eating well, and also making sure we, as much as possible, advocate for public health measures that doesn't leave all the choices and the burden down to individual women. But just to come back, sorry, just remind me the question you asked me before I went on my tangent about nutritional supplements.
Yes. The question is, how crucial is the role of the nutritional advice for PCOS patient? What role does it play?
So really, really important, but again, non-judgmental. These women do have a more rapid rate of weight gain from the age of 6. Even prepubertal girls who end up having PCOS have a more rapid rate of weight gain. If you have PCOS, you have more weight gain. If you have more weight gain, you have more chance of having PCOS. They work together. So you have a genetic predisposition which manifests more likely if you have weight gain. So the focus for us as clinicians is, from the moment we make the diagnosis, focusing on staying at the healthiest weight they can be through lifestyle. So prevention of weight gain is a really big aim and a really important goal and a big achievement. So if you have women coming in to see you, they may lose 5% of their body weight through lifestyle. They won't retain it sustainably. So if they're wanting to improve fertility or do something acutely, fine. But for most women, we reserve lifestyle for the intensive lifestyle treatment for the intention to prevent weight gain. In other words, to maintain their weight, and metformin helps with that. And that's a realistic goal that pretty much most women with this condition can attain. And the evidence would suggest that. What lifestyle alone can't do is sustainably, dramatically reverse obesity or significantly high BMI.
Right. Thank you so much, because this was a really important input, because we as clinicians generally, we've gotten desensitized. We are not saying with as much conviction that we should be telling them that this is really important and this is what will help. And there are a lot of now, the luxury of dietitians and nutrition specialists are not available at every nook and corner in our country. And it's just, under the carpet. So FIGO nutrition checklist, again, we are popularizing that, preconception, conception, and beyond, because it just takes less than a minute to administer that. At least they begin to think about nutrition and start counseling, being cognizant of time. We just close with the last 2 questions from Dr. Sonia Mandappa from Mysore. Her question is DHEA included in the investigation checklist?
No, and very specifically not, because it's not specific enough. So that means that what we often see is we'll have women who may have a normal total testosterone, even a normal free androgen index, but they'll have a mildly elevated DHEA or a mildly elevated androstenedione, and they often get sent to the endocrinologist for review. And yet the problem is they were just not sensitive enough. So the only time we would advise doing the other androgens is if you are concerned they might have an adrenal tumour because they've been rapidly virilized, or they've got very severe hirsutism that's been onset later in age, or something atypical about the history. Otherwise, we do not do the test, because even if it's free and it's included in the panel, the problem is it's often abnormally high, just marginally high, and it doesn't mean anything. So we advise not doing it because it's too sensitive and not specific enough for this condition.
Right, excellent. And Sonia, so another question was actually, Madhuri, related to the dysglycemic or hyperglycemic status in these women. In FIGO, we have stratified the way that we diagnose the hyperglycemia in pregnancy as to the feasibility and resource constraint in the low middle income countries, in which we have said that it's okay to do a non-fasting 75-gram 2-hour one-time testing. But her question was, does that even hold good for the PCOS patients? And I think you may say a clear yes or
I
no,
think if you
because
do an
that's
entire GTT for a PCOS woman for the first time, probably when it comes to your obstetrics, probably doing it just one step is where it's for general screening is important. That's what I think. And the other most important thing which I would like to convey is that PCOS starts in utero, and therefore prevention is very, very important, especially counseling the mother who is a PCOS, who is obese, so that we keep the androgen levels and the insulin levels low in the mother so that the future generation is not affected, and especially because it can result in several epigenetic changes as well as also induces PCOS in the next generation. Yeah, Helena,
And if I could,
Helena?
sorry, I would agree with you. If I could just add, if you're going to rationalise the OGTT, so it should be a 75-gram, not a 100-gram. By the way, that was the one other question. If you're going to rationalise it, the fasting and the 2-hour would be the key ones to do. Please don't omit the fasting, even though it's less of an issue. For example, in reproductive age women, it's still very sensitive in terms of picking up hypoglycemia, especially in pregnancy. So it would be the baseline, the 2-hour, but and the 1 hour is probably the most arbitrary if you can't do all of them. But I would agree, do them all the first time. And then depending on the risk profile, if it's a 19-year-old young woman who's relatively lean without a strong family history of diabetes, although I don't find that in many of my Indian patients, I must say, but if it's not there, you may, and they're not putting on significant weight, you may not choose to do an OGTT the next time. You may choose to do a fasting glucose because you think the risk is low. But if you've got someone who's got rapidly escalating weight gain, high family history, they're getting a little older, or they're considering conception, you would always do the full OGTT. So risk and balance with you and the patient. I know it's not a nice test, but it is such a high prevalence of diabetes at such a young age. I have a very large practice of adolescents with PCOS and type 2 diabetes who would have been completely missed, and also who respond really well to metformin. So very simple interventions early. So please, where you can, do the full test, but otherwise fasting in 2 hours.
Thank you so much. Because I think, the preventive care, and when you have the time, every footfall that comes to your clinic, think ahead, think what you would advise her. Don't lose the opportunity to do multiple things at that one visit, no matter for whatever reasons that she may have come for. I was actually going to close with that question, but there's just one more I'm tempted to ask. It is by Aishwarya Rayon, who says, anything on PCOS related to hair fall?
Related to?
Hair fall.
Oh, yeah. So
And
this is a very distressing, and I'll get Madhuri to comment on this. This is really distressing for young women. So hair loss is a feature of PCOS. It is exacerbated by weight gain and adverse lifestyle, and it is hard to treat. So if you see it, get it early. Make sure you assess them for PCOS. One of our problems is we don't get through enough to our dermatology colleagues, and they'll often just put these young women on anti-androgens without contraception, which then puts them at risk in pregnancy, but also makes the menstrual cycle irregularity worse and doesn't treat anything else. So first, make sure we're diagnosing the PCOS. Second, optimise the lifestyle and healthy diet as much as possible. Third, this is the indication where I would use both the pill and anti-androgens all at once and hit them reasonably hard, because it can be quite devastating.
Yeah, I think
Would you agree, Madhuri?
Yeah, repeatedly the points are coming forth with all the discussions, Madhuri and Helena, that really you need to think, you need to tailor, you need to individualize and personalize treatment, which is going to be, a game changer in the future. And Madhuri, Helena was just asking you whether you agreed with her last comment on the issue of hair fall. Yeah? You have anything to add
Yes.
on that?
No.
Okay, great. So we will close with a formal thank you, but I would just like to update both our distinguished speakers that the reviews we've got from the delegates, they say it's an excellent webinar, crystal clear points, makes us think about our treatment change that's going to happen post this webinar. So people are making a note of it. And as how we had discussed with the distinguished guests earlier, it will be worthwhile that all of those interested would get a copy of the recent guidelines and have it at their desk and be really cognizant about then and now and implement the best possible for every girl, every woman in their practice. And towards that, I really think this Knowledge Cafe has been exceedingly uh, interesting and informative, and many take-home practical points for which we would like, not only on behalf of Farmit, behalf of artists, behalf of all the delegates, a formal thanks by our project coordinator, who is a dietitian and nutritionist, Sheetal Joshi, who is a real asset in our setup because there was so much talked about the issues which she handles for us in our setup. Sheetal, over to you.
Thanks a lot, Hema ma'am. On behalf of Dr. Hema Divakar and Team Artists for Her, I would like to extend my sincere thanks to Dr. Helena Teede and Dr. Madhuri Patil, who is a real asset to Artists for all the programs and all the events. And they are the excellent researchers, I can say, because the guidelines, the new guidelines, what have been come, it is all the research work, what is happening, and they are excellent in research work. And thanks for giving the valuable insights on then versus now, what's new 2023 PCOS guidelines say. We appreciate and thank the support from Farmer team for their seamless coordination. And a big thank you to our own team artist, Dr. G.V. Divakar, who is the managing director, and Dr. Rita Singh, Dr. Purni Narayanan, who are our master trainers, and excellent team actually we have. And from research, we have Ms. Pallavi SP for their continued support. Thank you to all our delegates for those excellent questions you all have been putting in, and you join us every time, and you have always shown interest in whatever the new topic is and you all want to practice. Thanks a lot. And a special thanks to Dr. Hema Divakar for bringing such interesting topics and excellent experts globally, actually. That's really hats off to Hema ma'am, who thinks out of the box for such interesting topics. Thanks a lot. And I, Sheetal Joshi from Team Artists for Her, today I sign off with a promise we'll bring you yet more exciting sessions in the future. Thanks a lot, ma'am. Thanks, everyone.
Thank you.
Thank you,
Thank
Helena.
you very much.
Yeah, see you.
Namaskar. Thank you.
Bye-bye.
Bye-bye.